Welcome, everyone. My name is Sally Thorne, and I'm lucky enough to be your moderator for today. I'd like to welcome you to this month's rounds. I'm speaking to you today from the traditional, ancestral, and unceded territory of the Coast Salish people, including the Musqueam, Squamish, and Tsleil-Waututh nations, also known as Vancouver. And I'd like to thank all of you who have joined us or who are joining us virtually after the fact. Today, we're going to hear from our speaker, after which we'll open up the floor for any discussions, comments, or questions you might have. Feel free to put them in the chat during the session, and we'll take them up as soon as they arrive, or as soon as the speaker has finished. So it's my great pleasure to introduce to you the speaker for this month, Abosede Catherine Ojerinde. Dr. Ojerinde is originally from Nigeria, and in Nigeria, she was a registered nurse, a public health nurse, and a nurse educator. Her research intersects through various health domains, including maternal-infant health, medication errors, and health promotion among the underserved population. For her dissertation research, which was just completed and submitted, and she will graduate in just a few short weeks, she focused on Black African immigrant women's cervical screening uptake and experiences in the context of a comprehensive screening program in British Columbia, which, as you can imagine, is quite different from the Nigerian context. She remains focused on research which promotes the health and well-being of marginalized women. We're delighted that Dr. Ojerinde could join us today, and I'm going to hand over to you, Catherine.
Thank you so much, Sally. And good morning, everyone, and good afternoon for people in Eastern Canada. I'm going to be talking about cervical cancer prevention, specifically cervical cancer prevention. But before I get started, I want to acknowledge my supervisors, Dr. Sally Thorne, Dr. Fushia, and my committee member, Dr. Amni Kazanjian, for making it possible for me to complete my dissertation research. Also, before I start, I want to acknowledge that I live in Greater Vancouver, which is located on the traditional, ancestral, and unceded territory of the Musqueam and Squamish First Nation. And I welcome you all listening or joining us to take a moment to consider the territory on which you are. Yes, okay. I'm going to be presenting to you today the outline of my presentation today. I'm going to be talking about the origin of the study, the problem and significance, the background, literature review, the overarching study aim, the theoretical framework, research approach, methods, the findings, recommendations, strengths and limitations, and then the conclusion. I'm a professional nurse, and I've had engagement with individuals at different levels of the social class. And I have come to realize that people perceive realities in different ways, and they do not always conform to the ways of thinking that we may imagine the world. So this was my background, this was my thinking, this was what my methodology that I used in this study was based on. Next slide. In Nigeria, originally from Nigeria, as Dr. Stone has already mentioned, and I'd like to start the presentation by explaining how the study came about. It all started a few years ago while I was working on the medical oncology ward in Nigeria, where women diagnosed with cervical cancer were receiving treatment. And I learned from these women that their inability to attend cervical screening was because they were unaware that cervical cancer is preventable with the use of pap smear. So I became interested in this, and to fulfill my curiosity and because of my personal interest, I've also volunteered to deliver cervical cancer screening to women in my community, as well as to encourage them to attend cervical cancer screening. So this research was motivated by my own curiosity as well as my desire to contribute to disciplinary knowledge. It is good to know that in Nigeria, about 10% of women in Nigeria have ever had cervical screening. And given the absence of organized population-based in Nigeria and population-based cervical cancer screening program in Nigeria and across Africa, one may assume that when these Black African immigrant women immigrate to Canada, they may demonstrate a low level of awareness and uptake of cervical cancer screening. So the problem of this study and significance of the study was that there was, as I've said, there was no organized screening program, and about 70% of women in Nigeria and in other sub-Saharan African countries who were diagnosed with cervical cancer present with an advanced stage of cervical cancer. And talking about Canada, we have a comprehensive provincial screening program, which is available without out-of-pocket payment. And then there's a profound reduction in cervical cancer incidence due to screening and early detection, which allow for the treatment of the pre-invasive lesion. Evidence showed that cervical cancer is less likely to be detected early in immigrant women than in the general population because they are less likely than the general population to participate in cervical cancer screening. So what is cervical cancer screening? It's a screening tool that looks for abnormal cells, which may be in time develop into cervical cancer. And currently in Canada, it is recommended that women aged 25 to 69 years attend routine training every 3 years. Literature review. As indicated in the literature, no single factor could explain the barriers to cervical screening because different circumstances interact with women's gender role and immigration status to influence their screening uptake, making it a complex phenomenon to understand. Studies conducted among immigrant women from sub-Saharan Africa and living in UK, US, and Australia showed that their screening uptake is influenced by nuanced barriers that include several characteristics of culture, structural forces, and socioeconomic factors. According to the Canadian statistics, British Columbia is a significant receptor of, it's a receptor province for new immigrants. But little is known about the cervical screening experiences of Black African immigrant women in British Columbia. Although some authors have investigated the viewpoints of immigrant women and healthcare providers in Canada, the perspective of Black African immigrant women in British Columbia have not yet been explored. Also, how the broader systems and policies related to settlement and healthcare shape immigrant women's screening and healthcare digitalization in general have not been explored. Next slide. So it is as a result of this significant gap in the literature, the study aims to explore Black African immigrant women's perceptions and experiences of cervical screening in Canada for the eventual purpose of contributing to the body of knowledge to understand how to develop appropriate strategies to serving immigrant women from sub-Saharan Africa to Canada and possibly among women in Nigeria. So the following research questions guided this study. What are the barriers related to the different contexts of the Canadian healthcare system and society influence Black African immigrant women's cervical screening uptake? And the second question, how do Black African immigrant women in Canada conceptualize cervical screening? And how does their conceptualization influence the use or non-utilization of cervical cancer screening? The theoretical force structure that guided this study, design, and implementation included the included disciplinary orientation, socio-ecological theoretical framework, and philosophical assumptions. The socio-ecological theoretical framework was chosen because of its emphasis on understanding the dynamic interrelations between various individual and environmental barriers to cervical screening. The idea of grounding this research in the perspective of ID meant that, in the perspective of interpretive description, meant that I acknowledge the multiple realities exist and will influence the meaning-making process related to the cervical screening experiences of the participant. Therefore, in keeping with the perspective, the Black African immigrant women's cervical screening experiences was employed in a way that allowed for the description of multiple realities in these women's lives to be understood. Given that the nature of nursing is committed to understanding the contextual and lived experiences of the client and the interaction with the environment, interpretive descriptions, recognition of the socially constructed nature of human experience aligns with our view nursing practice. And as such, grounding the study in these three perspectives shaped the interpretation of the data. Next slide. To begin to address this gap in the body of knowledge, I employed a qualitative research approach, research design, drawing on interpretive description. Interpretive description is a method. It's a research approach developed to facilitate the development of disciplinary knowledge that can be used in the clinical practice. Its goal is to generate understanding of complex and situational knowledge. And its underpinnings, it recognizes that human experiences is contextual and socially constructed. It acknowledges that the influence of the researcher on the knowledge development and recognizes that reality is made up of social processes and human interactions. Methods. Although the COVID-19 pandemic disrupted my research and data collection plan, I was able to recruit and interview 20 Black African immigrant women in Greater Vancouver area. Through the use of purposeful sampling strategy, I used snowball and confirming and disconfirming cases. I incorporated the strategy of confirming and disconfirming cases to recruit participants who were as diverse as possible and to maximize the chances of obtaining rich data in order to address the research question. So I performed this after conducting a few interviews. I performed an initial data analysis to identify early emerging patterns in relation to the study purpose. By doing this, I could identify cases that captured the phenomenon as conceptualized in the study. Recruitment was by word of mouth and via social network. Next slide. Participant recruitment flowchart. 19 participants were recruited by snowball strategy and word of mouth. The numbered 1 to 10 circles in this figure you are seeing shows how participants were contacted in the social network. The black shaded circles in the figure represent 7 participants who were invited but did not respond. The circles numbered 1 to 10 were the intermediary individuals who provided me with the contact details of the identified potential participants that I followed by contacting each of the individuals. And the unnumbered circles were the 20 participants in the study. Next slide. Data collection. The data collection method was via the telephone. Delving into the participants' explanations was somewhat difficult for me during the research and required that I pay attention to the phrasing and clarity of my questions. I gathered data during informal conversation and through in-depth interviews. With the understanding that data collection in interpretive description can take many forms, I use analytic memos and a reflective journal to gather data as well. In addition, I use orienting statements such as asking the participants some questions. Like, so I'm asking you as an African woman to help me understand from your perspective what life is like for you here. So this was to encourage the participants to voice their perspective, and also I auto-taped all the interviews and transcribed them verbatim. In addition, in keeping with the constructionist epistemological assumption, I transcribed every enumerable comment in the interviews. This helps me to accumulate rich information to build a detailed representation of each woman's situation. Only one participant opted for Zoom interview, so only one Zoom interview was conducted for the study. Next slide. Data analysis. Data analysis in an interpretive description is an inductive and iterative process and involves immersing myself in the data rather, interrogating the data, and challenging my own ideas and assumptions as themes and concepts were identified to ensure that they align with the research questions. As I retrieved new information from the interviews, I compared it against the identified developing patterns and concepts. I shared my memos with my supervisors and they helped me push my ideas forward. I also employed intersectionality as an analytic tool to examine how the study participants' numerous interwoven social identities interacted with and influenced one another. Overall, the disciplinary orientation that inspired the study was a meaningful tool for informing the analytic lens within which I distinguished relevant patterns within the data. Finding the participants' socio-demographic characteristics. There are 13 married women, 6 single, and 1 cohabiting. 4 were unemployed and 16 were employed. 17 of the participants have had cervical screening done. 9 of them have had screening done in their countries of origin or other West African countries, as well as in Canada. 6 has been screened in Canada and 2 women had only had screening in their home countries. The remaining 3 women stated that they had never been screened. All the participants were from 9 sub-Saharan African countries. And their age range was from 25 to 55 years. The average age was 41 years old. Next slide. The findings were organized into 3 areas of focus. I integrated the participant narratives regarding challenges of resettlement experience and their experiences utilizing the healthcare system. These 2 were influential features as I considered to address the research questions regarding how the different contexts of the Canadian society and healthcare system influenced their screening uptake. This was done because insight into these experiences provided an understanding and interpretation of what was significant and meaningful to each woman to address the second question regarding how they conceptualize cervical cancer screening. So cervical cancer screening perception and experiences were conceptualized into four major themes: confusion conceptualization, competing priorities, concerns for modesty, and commitment to culture. So all these participant conceptualizations appears that the pattern of screening, their behaviors, and gaps in their knowledge of cervical cancer screening were all shaped by not only their African values and interrelated contextual forces, but also by the influence of the intersection of various contextual elements with the participants' socio-demographic context. Next slide. Next slide. The findings were explained through the lens of the socio-ecological theoretical lens because of the participant interconnected barriers to screening operated, because their barriers operated across and within various levels of socio-ecological theoretical framework. In order to understand the participant screening uptake, I interpreted their screening by using this socio-ecological theoretical, the lens of this socio-ecological theoretical framework, and it provided insight into how the characteristics of each level can either predispose or enable individual women to utilize screening services, and conversely, or may affect the individual risk of cervical cancer. So this means that the individual level, interpersonal level, organizational level, community level, and the system level all overlaps to influence a woman's ability or decision to use cervical cancer screening services. Next slide. The recommendation went into 3 areas of practice: nursing practice, research, and health policy. In terms of nursing practice, it is important for us, for healthcare providers, to understand these women's cervical screening needs in order to improve and align cervical screening communication for them and to facilitate equitable access to cervical cancer screening. Just a moment, please. Okay. Next, okay. Recommendations for research. Research exploring how to provide support and to allow members of this group to make informed decisions regarding cervical screening is needed. Then research exploring how to provide support to allow all members of this group to make informed decisions regarding cervical cancer screening is also warranted. In addition, research informed by a critical theory perspective could provide important insight into the ingrained power structures and their potential influence on cervical screening practices and healthcare utilization in general. Health policy. An upstream approach to address health and social inequities is warranted. and improving access to social services, community supports, and child health care may be beneficial as well. Strengthening existing cervical screening program at the provincial level to better support women who have immigrated from African countries may be beneficial as well. Next slide. Overall, the study findings, before I go to that, overall, the study findings point to the need for more active approach to communicate information about cervical cancer and ways to access screening that will increase awareness of cervical screening, such as community-based strategies. Moreover, given the study findings suggesting that greater awareness of cervical cancer is needed, cervical cancer is needed among the Black African women who have immigrated to Canada. It's also highly likely that similar efforts to raise awareness in Nigeria may be beneficial. Specifically for this group, an equitable and justifiable cervical screening program would be one in which any African woman, regardless of her circumstances, will have access to dedicated cervical screening services that have been adapted to specific needs of this group. So a complex strategy integrating several cervical screening models, including organized population-based cervical screening, could also be beneficial. The study strength. Interpretive description approach to building methods that are grounded in nursing epistemological foundations, adhere to systematic reasoning of nursing, and yield legitimate knowledge for practice is a strength for this study, because as it allowed me to really understand and provide adequate information. And also, the inherent flexibility in interpretive discourse methodology is a strength, as it provided a coherent logic and structure that was designed towards the generation of practice-relevant findings. Limitations. Disruption to the original study plan caused by physical distancing requirements associated with COVID-19 pandemic was a limitation for this study. And the study sample did not include women residing in other areas of the province, particularly rural and remote regions. Also, sub-Saharan African women in remote areas could have a different experience, and this study didn't include them. They were not included in this study. In conclusion, the study has demonstrated that support for cervical screening must include a commitment to addressing health disparities through the overall aim of achieving optimal health for all women. And it has reminded us of the need to pay attention to the needs of vulnerable immigrant women who are most at risk for poor health outcomes. Thank you for listening.